Welcome to the episode. I'm Dr. Armin Feldman, and as always, I'm here with my friend, colleague, and partner in Physicians Legal Consultants, Dr. Mike Bummer.
Hi, Armin, and hello to our listeners. It's nice to be back after a little break here. We're on YouTube again, of course. So if you want to tune in and see us on YouTube, you can just search for Physicians Helping Attorneys. And to our podcast listeners on iTunes and Google Play Store and all those places, welcome back to the channel. The reason we took a break, Armin, was a little bit sick. He was under the weather.
Yeah, unfortunately, I got an upper respiratory infection. Thank goodness it wasn't COVID, but it did knock me out for a couple of weeks, and I'm happy to be up and running and back on my feet and recovered.
Yeah, welcome back. I was worried about you there for a little bit. Getting sick is no fun at all.
Yeah, it wasn't fun. It was a below average experience.
While we were away, I had the opportunity to catch the great North American solar eclipse.
Yeah,
So
must be great.
for our listeners who are frequent know that I'm in the Pittsburgh region, and we're lucky about an hour and a half drive got us into totality,
Wow.
which I didn't really understand the difference between 99% and 100% until I saw 99% right, the minute before totality, and I was like, this is kind of neat, but it's still bright. And then the second it became total, it really was cool. It wasn't life-changing for me,
Right.
but it was really neat. Big white orb in the sky, and I would recommend, we won't have another one through the United States until 2044, but if anyone
I'm looking forward to that one.
yeah, we'll watch it together, okay?
Yeah.
So today's episode, back to business here, we have two really good standard of care reviews that we've done for attorneys in the past couple years. And we just want to run through those cases. We will share some of the angles that we've took, advice that we gave the attorneys, issues we ran into. And Armin and I are both going to do one. And before we start, I should mention that if you have your own case or if you have a question of any sort, the easiest way to get a hold of us is to email us at comments@physicianshelpingattorneys.com. And you can certainly find us on LinkedIn as well with just both of our names, Mike Bummer and Armin Feldman.
Great.
So
Mike, you gonna go first on the case?
yeah,
Okay.
sounds
Okay.
good. Sounds good. So this was a case that came to me from an attorney that I've worked with for quite some time. And he had a client who unfortunately, he was concerned had a missed cancer diagnosis. And I'll kind of start at the beginning for you.
Okay.
She, in her 40s, was diagnosed with stage 0 breast cancer. And she had a lumpectomy. That's essentially carcinoma in situ in part of her breast. It's very common, and the reason we do mammograms.
And
And
the prognosis on that?
excellent, 99% 5-year survival rate. Kind of loosely quoting that, but yes, very, very high survival.
Okay.
And she underwent appropriate treatment, no oncology treatment, and did well. And so then about 20 years passes, and on a mammogram, she's found to have multiple areas of calcifications, and in both breasts this time. And they do biopsies, and they find some both carcinoma in situ and invasive ductal and lobular carcinoma.
Okay. So she had either a new or a recurrence of cancer.
That's exactly right. And so she underwent bilateral mastectomy and chemo and is ongoing treatment with hormone therapy because the tumors were hormone sensitive.
Right.
And she's doing quite well. She's actually roughly about 5 years out from this treatment, and again has a pretty high degree of survival, north of 5-year survival rate north of 70 or 80% with this after her treatment. And funny enough, everything I've told you isn't directly related to this miss, but it sets up the kind of climate of the clinical scenario for this patient.
Okay. So it isn't related to.
It's not directly related, but
Not direct. Okay.
it plays into the question that the attorney asked me, and ultimately something we had to consider.
Okay.
She then has a concerning skin lesion on her arm, on her shoulder, and her dermatologist recommends deep removal with clear margins. So she's set up for the operating room to actually have this removed. And as part of that pre-op, because of her age, being in her late 60s, she gets a chest x-ray as well to make sure she's safe for anesthesia. Chest x-ray is, I'm deciding kind of how I want to show this, because it's what got missed is there was a 3-centimeter nodule in the left lobe of her lung on chest x-ray.
Okay. Suspicious mass in her left lung.
Yeah, funny you phrase it that way. The report of the chest x-ray actually says suspicious for neoplasm until proven otherwise.
Wow. Okay. Mm-hmm.
She undergoes the shoulder biopsy. No one tells her about the chest x-ray result.
Oh my gosh.
Now, 8 months go by, and she starts to have some shortness of breath. She sees her PCP, who pulls some records, saw that she had a recent chest x-ray, sees the report, asks her about it.
Well, wasn't that recent though, right, Mike? I mean, it was 8 months ago.
Eight months correct.
Right.
But as he was looking at her pertinent recent history, yeah.
Mm-hmm.
And she has no idea. Now everythting kind of gets thrown in the sky, and they run to get consults with an oncologist and with a lung cancer specialist. And it's found after biopsy and further testing that she now has a 10 to 13 centimeter lung nodule mass, highly suspicious for invasive cancer. They biopsy it and find poorly differentiated squamous cell cancer of the lung.
Oh, what a shame.
And she's currently stage 4, spread to the lymph nodes, receiving palliative chemotherapy.
Mm-hmm. Palliative meaning help her to live as long as she can, keep the tumor's size and down as much as possible, but it's not going to cure her.
That's exactly right. Some people, they hear the word palliative and they think that that's meaning that you're at end of life. But in terms of palliative chemotherapy, it's often just means it's not the intention. There's no expectation of cure, the way you phrased it, but that it is trying to keep it at bay to provide as many years and quality of life as possible.
Right. So just to clarify, she had this x-ray 8 months prior to it being discovered by her primary care doctor, and that's the first she heard of it, and probably the first that her primary care doctor knew about it.
That's exactly right. So the attorney's question for us was a fewfold, because they have a burden to meet. Was the negligence of the missed kind of diagnosis and missed management of that nodule isn't really in question here. But the bigger question is more causative, in the sense of, did that 8 months have a significant impact on her life expectancy and outcome?
Yeah, well put.
And in this case, it wasn't immediately obvious, because in terms of cancer timeline, each cancer has its own life cycle. And oftentimes a few months is really a drop in the bucket for a lot of cancers, and to people it would feel like an eternity. If you have a delayed appointment, if you're I mean, all of us are patients. Even the attorneys listening, even the doctors listening to this are patients. If you know you have a cancer in one of your tissues and you're delayed, for an appointment or surgery for 3 weeks, it would really eat at you. It would feel like, why are we waiting? But more often than not, weeks and sometimes even months do not have a major impact on the outcome of cancer treatments.
Yeah, I'm glad you said that because it's really important.
And our attorneys see a miss and a breach in standard of care, but it doesn't always have the impact on outcome that they would hope to support their case.
Mhm.
Now, in this particular case, I was able to, with my Rolodex of experts, I was able to talk to a lung cancer specialist, actually one of the best in the East Coast. And he's been doing this work since the mid 90s and is really regarded. He speaks nationally, and he really be hard pressed to find anyone better in this field to ask this question. And what we ultimately settled on, so I had about a 45-minute conversation with him just about this one delay, this one nodule. And that's what's exciting, able to offer this feedback to my attorneys after a high-level conversation.
Right.
And the
And that's really one of our areas of specialty, right, Mike? I mean, that's part of what we do is we can take a look at really any kind of situation, but in this case, cancer, and understand what the issues, ramifications, questions are, and then we can have our go-to curbside consult experts that we can then have a conversation like you had.
a very high level, efficient conversation, because I'm not privy to the exact conversations that attorneys have with potential expert witnesses,
Mhm.
but I have a feeling they're a bit less detailed and have less meat than most of the conversations that I have with these potential experts.
Sure. Makes sense. You're a physician.
And on this case, the expert did in fact believe that it more than likely had a significant impact on her outcome.
Mm.
It may not have changed that she ultimately was going to succumb to lung cancer in the next
Right.
5 to 10 years, but it the significant change in size combined with the opportunity to be a candidate for surgery
Mhm.
combined led him to believe that it had a meaningful, significant impact on her survival rate and her life quality.
Right. So, in his opinion, it was more likely than not, right, that this the miss on the X-ray is going to shorten her life.
That's exactly right. Yep. So then, as you know, Armin, we then are able to refer these experts to our attorneys, and the expert comes into the case with a really good primer from a fellow surgeon, a fellow physician, and they start cooking on their own, and they build their case.
Hmm. Yeah, great. I don't think that the attorney could have processed that case in quite the same way without that consultation. It was smart of the attorney to get it.
Yeah, thanks, Armin. I kind of humbly agree with you, and for the efficiency and for the affordability of what we charge, to me, it's I'm biased, but it was a no-brainer, and I really felt
Yeah.
like I added a lot of value.
Yeah, I don't even think that's a biased opinion. I think that's just so.
Would you like to share your case?
Yeah, yeah. My case is a rather sad situation. So, uh, this is a case of a 39-year-old man who went to a local medical clinic with complaints of depression. Now, a one of the things, and it'll become evident why this is the case, but one of the things that confounded this case is that about a year, almost a full year before this visit, he saw another medical team or an internist, and that internist diagnosed, and it's in the record, but diagnosed him with having hypomanic, not full blown manic, but hypomanic episodes interspersed with depression, which is one type of bipolar disorder. Now, why the client of the attorney, the patient at this clinic, same person, didn't bring that up, I don't know. And it's somewhat of a confounding factor that he didn't offer that history. But a couple of things happened. First, he came in and his chief complaint was depression, so they gave him a questionnaire to fill out, and a mental health questionnaire to fill out. And one of the sections, of course, there was a section on questions about depression, but was a section, it was actually labeled as bipolar questions. And he answered in a positive way to several of those questions about having manic episodes, and actually had written onto the form that in the past he thought he had bipolar disorder. So he then is seen, and this isn't clear in the record either, but he's certainly seen by a physician's assistant. Now, it wasn't clear whether he saw a physician as well, or whether the physician assistant consulted with the physician at the time of the appointment. Just wasn't clear in the record. But the client was saying, well, I've got all these symptoms of depression. I don't need to go into what the specifics are, but it was clear that he was having depression. And so the healthcare provider, the physician's assistant, decided to start him on fluoxetine, Prozac, at 20 milligrams. And by the way, the date of this appointment was May 2nd.
Okay.
On May 13th, unfortunately, this man committed suicide.
Oh, man.
Yeah, horrible, right?
Yeah.
39 years old. So the attorney wanted to know if the treatment was below standard, right? And so it was my opinion that it was. It's confounded by some things I'm going to talk about in just a minute, but it was my opinion that it was, for two reasons. One, he filled out a questionnaire that apparently the treating people did not read.
That has to happen all the time. All the time.
Yeah, I think you're right about that, Mike.
Yeah, it doesn't make it. I mean, it is a breach in standard of care, and it is a major problem. But those self-reported forms often get glossed over.
Yes, I think you're absolutely right about that. It's so routine, right, that they may not even be viewed by the treaters.
Especially with the digital medical record, because a lot of times those papers are just seen now as almost just extra trash almost. Like,
right.
I hate to put it that way, but yeah.
Right. So that was a miss, right? But in the notes from the visit, the treater didn't mention either ruling in or ruling out any symptoms of mania or hypomania. So just for our listeners, the symptoms of, it can be hypomania, meaning it's not quite as full-blown, or full-blown it would be mania, but the symptoms would be being elated or having an overly elated mood for a period of time, hyperactivity, grandiose thinking, racing thoughts, difficulty sleeping, loss of appetite, feeling agitated, which, by the way, was a question on this questionnaire, trouble concentrating, getting irritable, spending too much money, talking too fast, using poor judgment. Well, none of these questions were asked. And so it was kind of a double whammy. Not only did the treating healthcare provider apparently not look at the questionnaire, but just took the depression on face value and decided to treat the depression without making any determination about mania. Now, you know this, Mike, but this is why this is important. So if somebody has bipolar disorder as opposed to major depression, they really shouldn't be placed on an antidepressant medication, sometimes at all, but certainly without being on a mood stabilizer to protect against the antidepressant medications biochemistry tripping off either a manic attack or a hypomanic attack, or more, or it could be, and I think it was in this man's case, rapid cycling.
I
So
almost
rapid.
imagine a yin and yang, where in bipolar disorder, there's the depression and the mania that are always kind of applying force to each other. And if you get rid of the depressive side with those medications, maybe the mania is left. It's not a good analogy, but
Yeah.
unchecked in a way. Does that make
It's the
any sense?
biochemistry. I mean, the very chemicals that in the brain that you're trying to stimulate with the antidepressant medication can kick off a hypo or full-blown manic episode.
Okay.
And that can result in a lot of problems. Doesn't obviously always result in somebody getting having a rapid shift from mania to depression, getting depressed and committing
Okay.
suicide, but it was in this case.
That's-
So that's what happened, and it's even more confounded by this issue. If you go to the medical research, literature, there's, even after many years, there's still a debate about whether or not you should treat somebody with bipolar disorder, depression, with antidepressant medication. So even in the insert for the Prozac, it says that if you're going to make a clinical decision to treat the depression with antidepressants, you should add in a medication called olanzapine. Now, olanzapine, it's an antipsychotic medication, but as you know, Mike, many of these antipsychotic medications can act as mood stabilizers. And so even in the insert for the medication, it says, if you're going to do that, first get the person on olanzapine and also carefully monitor, right? So this man was told to come back in 4 to 6 weeks.
Remind me again, was this a PCP or was this a psychiatry office?
No, it was a medical clinic.
Like a general
medical clinic. It
Okay.
wasn't a mental health clinic.
Do you think that changes their burden at all, or does it not let them
No.
off the okay?
Yeah, no, I don't think it does. I mean, not everybody knows about psychiatric problems, but almost all, and especially any good family medicine doctor who will routinely be prescribing these medications and would be well versed in this.
Okay.
So, but if you go to the literature, there is this debate, and there are confounding studies. Some studies say, no, if you protect with a mood stabilizer, and particularly if the person has hypomania as opposed to full-blown mania, bipolar 1 as opposed to bipolar 2, you make a clinical determination that the depression is severe enough that you can treat with antidepressant medication. Other articles say never do that. In fact, I read one article in preparing for our podcast, and the title of it was Antidepressants in Bipolar Depression and Enduring Controversy. And that article was a meta study review. In other words, it reviewed many different studies, and the conclusion was, we're not sure. Use your clinical judgment. So that's the backdrop to, well, is this below the standard of care? And I think what pushed it over, so somebody could argue, well, it's debated, so it might not be below the standard of care. But I think, in my opinion, to a reasonable degree of medical probability, what pushed it over into being below the standard of care with this horrible outcome is that it appears from the medical record that whoever saw this client, whether it was a PA, PAN, a physician, or whatever, they did not ask the proper questions to even deter. If somebody comes in with depression, one of the things you have to ask them about, if you don't know them, is go through and ask them about all those manic. Have they ever been manic, or have they ever been hypomanic? That wasn't done. And they didn't review their own questionnaire, in which it was clear that he had a history of mania. So for those reasons, it was my opinion this was below the standard of care, and there was merit in terms of going forward.
It makes it hard to defend that the decision to give an antidepressant alone was reasonable whenever they can't prove in any way, shape, or form that they even considered that as their decision making or controversial decision making.
Right.
It was completely missed.
Right. Now, I will say, absolutely, I will say that this isn't a common occurrence, right? I mean, you can give somebody in this situation an antidepressant, they become manic, but they're not droves of people that are then killing themselves, right?
Yeah.
This was, I mean, it's not good, but it's not fatal either. But in this case, it was fatal. It was a fatal mistake.
Are there any other circumstances, because this is in your wheelhouse, where antidepressants are prescribed when they shouldn't be?
This would be the main one.
Okay.
Yeah, this would be the main one.
Okay.
You risk putting the person into rapid cycling by mania, depression, rapid cycling bipolar, and during the depressive phase, bad things happen. In this case, it was a suicide.
What's the recommended time frame for follow-up after starting an antidepressant for the first time?
Again, I don't think there is a set standard for it that you can say, oh, you should, but you certainly want to see the person within a week.
That's what I was thinking, is that, months is too long. Yeah.
Yeah. And instruct the person, if you have this, and this symptoms, pick up the phone and call the clinic immediately, or go to the emergency room.
Great case, Armin.
Yeah.
I mean, tragic.
Unusual.
Yeah.
Tragic and, unusual.
Well, I think I'll just mention, again, if anyone has questions along these lines, has a case, whether it's a medical malpractice question, a merit question, causation, or personal injury related, as you know from our other episodes, we
or
do
workers' comp.
Workers' comp, anything related to the personal injury plaintiff's representation, let us know. You can email us comments@physicianshelpingattorneys.com. Find us on LinkedIn. Of course, subscribe, whether you're hitting that subscribe button on YouTube or whether you're following on your podcast app.
Great. I think you summed it up, Mike. I want to thank all of our loyal listeners and all the loyal people we have watching us on YouTube. And we look forward to having you on the next episode.